Okay, well, welcome everybody to our monthly developmental disabilities research and clinical and research rounds. This month rather, we have two people presenting together, and it should be a bit different from other things, but also really interesting and of tremendous interest for a variety of reasons and importance, especially given the cost of certain things now. So we have two presenters today. So Gemma Graziosi and Sam Officer. So Gemma is a PhD student at Western, working with Nicole Neal at the is it School of Education or Faculty of Education?
Faculty of Education.
Okay, the Faculty of Education. So, Emma is doing her PhD, as I said. So, Emma did her undergraduate degree at York and has been working as a research assistant as well, and is doing a PhD. Also, I should point out that Emma won the Benjamin Goldberg Research Award last year, I believe, so a grant, and so Ben Goldberg is actually one of our attendees here today. So Ben, you can see where the money named after you is going to, and how well it's being spent. And the other person who Gemma is presenting with today is Sam Officer, who is a master's student at the University of Toronto in economics, and who did his undergraduate degree here at Western in financial economics before moving to the U of T, and has been working on a research project as a research assistant. And so today, Gemma and Sam are going to talk or present on the impact of autism spectrum disorder on families in Ontario, economics, and beyond. So, if you guys want to take it away.
Sure thing. Okay, should be screen sharing now.
Yep, looks good.
Beautiful. Yeah, so thanks everyone for joining the presentation today. This project has been an ongoing collaboration between economists at King's College, as well as psychologists at Western University. And although they aren't presenting with us today, this research wouldn't be possible without the ongoing support of Dr. Jingjing Zhu, Dr. Renfeng Tian, Dr. Felipe Rodriguez, Dr. Rachel Birnbaum, and Dr. Nicole Neal. All these researchers have been brought together by a shared desire to further our understanding of the lived experiences of autistic individuals and their families, and this project is really one of our many pursuits in this area. This specific project on the economic impacts experienced by the families of autistic individuals in Ontario has been in the works for a few years now, and Samuel and I are excited to share some of what our latest data has shown. So before we begin, it is important to provide some crucial context regarding autism. First off, autism is a neurodevelopmental diagnosis that has been exponentially more commonly diagnosed in recent years. According to Statistics Canada, in 2019, approximately 1 in 50 youth were diagnosed with autism. And when examined by province, Ontario was among those with the highest prevalence rate, with about 2.1% of the population being diagnosed. Now, autism is typically diagnosed in early childhood, so it is easy to forget that it is a lifelong diagnosis that also affects adolescents and adults. Autism symptoms and presentation are very likely to change as individuals age, and as a result, the support needs of autistic individuals significantly vary throughout the lifespan. This not only affects autistic individuals themselves, but also their families. And among those most frequently and strongly affected are the caregivers. Caregivers sacrifice their time and well-being to support their loved ones, and research shows that oftentimes caregivers of autistic individuals may experience impacts to their finances, relationships, quality of life, and more. In particular, there is growing concern about the economic impact of caregiving, both in terms of direct costs and broader financial implications for families. Existing estimates based in the United States have found that autistic children have higher levels of healthcare office visits and prescription drug use, as well as higher out-of-pocket healthcare costs overall compared to typically developing children, as well as children with other intellectual and developmental disabilities. On the therapeutic side of things, annual expenses for intensive behavioral intervention are estimated to cost between $5,000 and $80,000 Canadian in Ontario, depending on the child's needs. And in addition to these different healthcare and therapeutic costs, families with autistic children often encounter some significant non-healthcare related costs, with some studies actually suggesting that these non-healthcare costs are actually much higher than the healthcare costs. And these often include areas like education, childcare, and even transportation to and from the different services. In combination with all of that, loss of productivity within one's employment also poses a major financial impact to family members, resulting in an average annual income loss of about $6,200 American, which accounts for about 14% of households' total incomes, which is a significant chunk. Of course, all of this in combination with some other unrelated stressors places a major mental burden on families, which, if not supported adequately, could negatively affect one's life significantly. And although autism has been getting increasingly more recognition as a diagnosis, which is fantastic, it also highlights an increasingly urgent need for accessible supports that respond to the various needs of these individuals' families. Now, given that there are international differences in policies for healthcare, education, and other domains between the States and Canada, the economic impact associated with autism in Canada are very likely to be different from what research in the US has shown. However, as per the usual, there is a relative lack of research that has examined the experience of Canadian caregivers, let alone those in Ontario, where the prevalence of autism is among the highest. Additionally, while there is research on the economic impacts of autism broadly speaking, it is a bit less clear how families of different demographics, including like geographic location and socioeconomic status, are affected financially. So those were some research gaps that we really wanted to address. So that brings us to the objectives of our research, which are threefold. First, we wanted to quantify economic, practical, and social impacts experienced by families raising autistic children in Ontario. And we also wanted to assess how these different financial challenges and caregiving related employment effects are different across families based on different characteristics. Based on the results of those two objectives, we then wanted to generate some equitable and practical policy solutions that address barriers to support and promote family well-being. Now, given that Ontario is one of the provinces with highest rates of autism, and the research team is also based in Ontario and more familiar with its policies and guidelines, caregivers in Ontario were the primary focus for the study. So I'll mention again, this project has been going on for a few years now, so it has gone through several phases. Just to recap, we began in 2023 with a review of the literature evaluating economic impacts of autism with a focus on North America. Based on the validated instruments we identified in that literature review, we created an initial survey that we presented at a workshop with 9 multidisciplinary experts that have experience working directly with caregivers. Their feedback was incorporated into our next version of the survey, which we shared at a focus group. The focus group was conducted on King's campus, and it had 8 caregivers trial running the survey in person, where they're able to provide notes on the clarity and relevance of the questions included. After making extensive revisions, we released the pilot version of the survey in 2025 to test out its feasibility in a digital format and obtain some preliminary results. Now, if anyone in the audience attended the Developmental Disabilities Research Day last year, you might be familiar with that data since I presented it there. And we ultimately decided, based on that data, to broaden the inclusion criteria to allow caregivers of children ages 1 to 25 years old to participate, as opposed to caregivers of children 18 and under. Since then, the final survey was released in fall 2025 and has been open for participants since. Now, in terms of the analyses that we did, we wanted to take a mixed methods approach to allow for both quantitative and qualitative insights. The initial analyses included generating summary stats and distributional patterns, which then informed regression analyses. Concurrently, content analyses were conducted on survey questions, with long answer questions informing some additional thematic analyses. Finally, in terms of the current demographics of those who have completed the final study as of now, we have recruited about 300 caregivers with a mean age of 44 years, the majority of whom identify as female and white. And in terms of the household composition, the majority of participants have one child diagnosed with autism, whereas 15% have 2 autistic children, and 2% of those who've completed have 3 or more autistic children in their household. Now, as for the children themselves, while they didn't complete the survey, we did collect their demographic information. There are about 350 identified in our surveys with a mean age of 11 years old, 70% of whom are male. Interestingly, over 70% of the children identified also have co-occurring challenges, whether it be medical or a mental health diagnosis, such as an intellectual disability or developmental disability. So with the methodology and demographics out of the way, I'm going to pass it over to Sam to share some of our quantitative findings regarding the costs experienced by families.
Thank you, Gemma. So the first cost we're going to start out with is the service and therapy costs, which are one of the main direct cost categories we have. So we can see a key result here is that about 73% of families reported having barriers in accessing needed autism-related care in the past year. The main reasons being cost, lack of available services, and long wait lists. So even before looking at dollar amounts, we can see that access itself is a major issue. For the families who are reporting service and therapy costs, the distribution is quite uneven. We can see a mean of $8,753 with a median of about $1,240. The gap tells us that most families have lower or moderate costs, but a smaller group faces very high expenses, pulling that average upward. We also have two pie charts here. One shows us that costs are concentrated in certain service areas, especially being ABA or behavioral therapy, as well as medical visits. On the coverage side, costs are spread out across out-of-pocket payments, OAP, OHIP, private insurance, and other sources. So the coverage exists, but it's fragmented. Families aren't relying on one clear source of support, and a large amount are subject to having to pay out of pocket. So this is a regression we did. It looks at which factors are associated with higher child level service and therapy costs. A quick rundown about these visuals and variables discussed is that they're not the only variables that were included. They're just the variables of interest, specifically variables that showed a significant impact within the dependent variable, in this case, the service and therapy costs. So the main result we found for this is that higher support needs strongly predict higher service and therapy costs. And this makes sense because children who require support across more areas of life are likely to need more intensive or frequent paid services. Children with an additional diagnosis also have much higher expected service and therapy costs. In the model, they have an IRR of about 2.68, meaning their expected costs are more than twice as high compared with children without an additional diagnosis, holding other factors constant. And a small clarification for IRR, it's the incidence rate ratio. It tells you how much the expected rate of an outcome changes with the predictor increasing by 1 unit, holding other variables constant. An example could be an IRR of 1.25 means the outcome is expected to be 25% higher. Or vice versa, an IRR of 0.8 means the outcome is expected to be 20% lower. Household income and the number of autistic children are negatively associated with per child service costs. For household income, this may mean some service costs are absorbed through private insurance, employer benefits, or other payment channels rather than just showing up as direct reported costs. For the number of autistic children, this may reflect that when there are multiple autistic children in the household, costs are spread differently across them, or families face limits on how much service they can afford per child. Overall, the model shows that service costs are closely tied to a child level complexity. Next are the extra costs, which are still direct costs, but they're different for medical or therapy costs. Extra costs include things like living expenses, special food, private school childcare, respite care, travel, administrative costs, tech, and therapy equipment and materials. So they're costs families face because of autism-related needs, but they're not always captured by traditional medical or therapy spending. The key point here is that 95% of families are reporting extra costs. So it's not a small or rare category. The average here is $40,342, while the median is just over $13,000. Again, mean, much higher than median, tells us the costs are highly unequal, with some households facing much larger impacts. The important policy point is that these costs are all out of pocket and they do not receive the same kind of coverage as medical or therapy costs. So even if families receive some support for services, they may still face large uncovered costs in daily life. So this regression is looking at what predicts higher extra costs. We have a dot and whiskers plot there. The strongest result is extra costs are significantly higher for households where all ASD children are 18 or older. We have an IRR of about 4.53, suggesting much, much higher expected extra costs compared with the reference group. This matters because it may point to a certain support gap after childhood. Families may continue paying for care-related needs after age 18, but child-focused public supports may decline or become harder to access. The model also shows that households with at least one higher support needs child have about 46% higher expected extra costs. It's important because it shows extra costs aren't just optional household spending, they're also linked to the intensity of care needs. Households with at least one child with another disability also have about 43% higher expect extra costs, which suggests costs increase when autism overlaps with other disability-related needs. And finally, household income has a negative and significant relationship with extra costs. Could reflect differences in coverage, employer benefits, ability to absorb costs elsewhere, how expenses are reported. And this slide is the broader picture, broader direct cost picture. It's the mix of the two, of course. So the main message is that these direct costs vary widely. We have 65% of families reporting spending more than 10,000, 19% exceed 50,000, and 6% exceed 100,000. So it shows that while not every family faces catastrophic costs, we still see a meaningful share that do. Home modifications are another example. About 47% report needing home modifications with an average cost of $445 annually. These modifications can include things like increased security, surveillance, sensory equipment, and repairs. The overall mean direct cost is just over 32,000, while the median is just over 15,000. Again, same theme. The mean is much higher across the median, reinforcing the direct costs are highly unequal across households. So the direct cost impact is not just about averages. Some families are facing very large expenses that could be financially destabilizing. This quote provided in the survey by one of our participants, it doesn't say much that the data hasn't already shown, but what it highlights is that families experience multiple costs across several areas simultaneously, and that these costs steadily accumulate over time. Furthermore, many of these costs are ongoing, and it's unlikely that families will be able to fully eliminate them, such as childcare, transportation. The best families can do, as indicated in our survey, is mitigate these costs where possible. In this case, by participating in therapy to reduce destructive behaviors and hiring an accountant to save money via taxes. So now I'll move from the direct costs to the indirect costs. So indirect costs are different because they're not necessarily money that families are paying out. Instead, they're income or work opportunities that families lose because of these caregiving responsibilities. For income loss, caregivers alone are facing up to $26,000 in lost income annually due to their caregiving responsibilities. The mean annual lost income is $26,600, just over, while the median is $15,000. The charts show that many respondents lose working hours, some experience very large income losses. This means the economic impact is not just about paying for services or extra costs. It shows up in a reduced ability to earn income as well. It's important because a family may not always report the highest out-of-pocket costs, but they could still face a serious economic impact if caregivers reduce their working capacity as well. So this slide's looking more directly at the employment effects. About 71% of families report that at least one household member's employment was affected. It's a large share, and it shows that caregiving responsibilities are in fact affecting labor market participation. The effects are also unequal by family member. About 82% of the affected respondents are mothers, while 27% are fathers. Suggests that caregiving-related employment effects are not evenly distributed within households. The data shows that 141 respondents report lost working hours compared with about 43 partners. So respondents lose an average of 15 hours per week, while partners are losing about 17 hours per week among those affected. The main point is that autism-related caregiving affects household income and labor supply. It's not only a health or service access issue, it's also an employment and income issue. So this regression looks at whether high support needs are associated with a greater likelihood of caregivers reducing work hours. And the result shows that higher support needs are associated with a higher predicted probability of work hours. In the graph, households with a high need child have a predicted probability of around the mid 40% range, while households with a high need child are about 60%. This is important because it connects care intensity directly to labor supply. When support needs are higher, families are more likely to reduce paid work. Families may face higher direct costs while also having less capacity to earn income. It's why direct costs are so important. They're capturing the economic pressure that's missed if we are only looking at bills and receipts.
Now, when asked in the survey, approximately 64% of caregivers indicated that they've previously turned down a job opportunity due to their caregiving and support responsibilities towards their child. And many people had also elaborated on why that was the case, so we'll get into some more qualitative results. So, caregivers identify that there is often a conflict between the demands of a job and their caregiving duties. And when raising autistic children, caregivers may find themselves requiring more time to coordinate services, tend to their child's needs, or even get called away for emergencies. And this is especially true for caregivers of children with higher support needs, such as those with unpredictable behaviors. Unfortunately, employers don't always grant caregivers the time and flexibility necessary to step away from work, which then leads to most caregivers having to turn down opportunities, cut back on their working hours, or leave their jobs entirely. And some caregivers, due to the high time and resource demands, find themselves unable to return to work at all. Thus, we find that caregivers often strongly value paid employment opportunities that have greater flexibility, include flexible hours, the ability to work from home, or just generally more accommodating of taking sudden leave. Now, we've included these two quotes here since they really highlight the opposite experiences that families can have with employment while caring for an autistic individual. On one hand, you have a family with a single source of income where the husband has to work long hours to support his family. He also has to be very particular about where he works in order to avoid disrupting his child service provision. Meanwhile, the partner is unable to work and supports their family because of their child's intensive support needs. On the other hand, we have two caregivers with the ability to balance the time between their work and caregiving duties more effectively due to the increased flexibility of being self-employed. And this really highlights the difference that one factor can have on a family's overall working dynamic. So, to compensate for the large number of expenses and productivity losses, many caregivers report cutting specific types of quote unquote luxury costs. And some of these luxuries are relatively superficial, like some recreational activities like going on vacation, paid subscription services, or travel. However, others could be considered a bit more essential, like paying for food to go out, paying for clothing, and even one's own personal care. In addition to these cut costs, some other cost-saving measures that families have employed include purchasing specific vehicles that might be more fuel efficient, relocating houses to be closer for traveling purposes to services, doing shared housing to cut back on living costs overall, whether it involves being in a group home or living with family, as well as making investments such as in savings accounts like the RDSP account, or even investing in stocks to potentially increase one's revenue. And unfortunately, sometimes these efforts aren't enough to save what is necessary to support one's family, and some end up acquiring debt.
And debt, this is one of the clearest signs of financial strain. We can see that 45% of these families are reporting new or increased debt just to cover the expenses related to ASD childcare. The mean debt of about 40,894, median 9,900. Again, same theme. The mean median gap is showing that the debt's highly uneven. Many families may take on some debt, while a smaller group is taking on extremely large amounts. The debt matters because it's turning current care costs into long-term financial strain. Families may be using borrowing as a coping mechanism when income, benefits, or public supports are not enough to cover costs. So debt isn't just another cost category, it's evidence that some families are financing autism-related care through private financial risk.
And once again, we have two quotes here that highlight the different experiences that caregivers can have with managing costs. Some of the examples we have here include spending less on going out with friends and family, travel, leisure, investing in the RDSP account to have savings for when the caregivers are no longer around, even accepting gifts, which I haven't mentioned is something that some people do to offset costs, as well as what we see in the second quote with shared housing, mindful use of one's vehicle, and unfortunately accruing debt over time. Something else that these quotes also highlight are the different attitudes that people can hold towards cutting back on those quote unquote luxury expenses. When some are more accepting of this reality, others and are justifiably disappointed that they aren't able to fulfill some of the goals or the dreams that they originally had. And it ultimately comes back to having to prioritize the cost of caring for an individual, including therapeutic services and extra costs over other things that might be considered optional. Now, going back to a statistic Sam mentioned earlier, approximately three-quarters of participants in the study mentioned that their child has care needs that weren't being met within the past year. And looking at the breakdown of the reasons why, it paints a really compelling picture. Sam already explained how the cost of services are a lot for families to manage, especially when a lot of that is being paid out of pocket. However, the second most common reason relates to the waitlist for services, with about a third of participants identifying that as problematic. A consequence of the increasing prevalence of autism is that there's now more demand for services and funding than ever before. While some services are very plentiful, such as ABA, others don't really have the staff or resources available to handle the number of individuals who wish to participate. One of the biggest examples of this is with respite services. As the population of autistic adults continues to increase, and caregivers are unable to adequately support their children as they age. As a result, some families are waiting months or even years to receive any type of service, let alone one that is actually a good fit for their family. In regards to the lack of information on professional help, which about 30% of people identified, typically after receiving a diagnosis, many families found themselves having to navigate autism services independently. They often became overwhelmed by the amount of information presented to them, which hindered their ability to effectively navigate services, which includes assessing whether a service is a good fit for their child, whether they're eligible to receive the service, how to apply for the service, and how to initiate and maintain the service delivery process. And this process itself is made harder by the fact that service navigators, whose job it is to aid in this process, are often overwhelmed and unable to provide the individualized support that families need to do effective service navigation. Finally, speaking to the 27% of people who said there's no available services, this not only speaks to services being over capacity, but other limiting factors, including aging out of services or otherwise being deemed ineligible to participate, or a lack of staff who are qualified to provide services, or even geographical limitations to service availability. In particular, people in rural areas have a harder time locating services just due to a sheer lack of numbers. And again, these two quotes here clearly exemplify all four of these limitations, and they really emphasize how there are often multiple factors in play that limits families' abilities to receive the support they need, whether it is due to the restrictions on funding or the locations of specific service providers, or just a lack of information that prevented someone from taking proactive action to engage in services and save money. Clearly, many families are unable to get the specific supports they're after in a efficient manner. Which brings us to this point where in our survey, we asked if caregivers would prefer to receive more funding provided directly to them or better quality public services, which are two things that we've identified are clearly lacking. And as you can see here, both outcomes are desired by caregivers, although direct funding is slightly more sought after. People who would prefer direct funding have stated that current funding sources are often restrictive regarding what they can be put towards. For example, there are many funding opportunities available for ABA services since it's a gold standard intervention, but not every family requires ABA services. Meanwhile, other service needs that families have aren't necessarily being funded as adequately, which results in needing to pay out of pocket or going into debt. Money being given directly to families would allow people to choose where exactly they want to spend their money, including on those extra costs like repairing damage or buying groceries or paying bills. On the other hand, people who wanted better services in the public sector are saying that there aren't enough services available, and those that are available have very long wait lists, so really they aren't available. Even though these families receive funding that they could put towards services, there really isn't anywhere to spend it due to that lack of availability. Better services then could entail several things, including a greater quantity of services, especially specific high demand services or services in rural communities, greater integration and communication between service providers, as well as a greater amount of support from organizations on how to navigate services. Finally, although the focus on the presentation so far has been on the economic impacts experienced by families of autistic individuals, I would be remiss to ignore the many other social and emotional impacts these families experience day to day, especially as some of these impacts are a consequence of financial decisions made to support one's family. Beginning with recreation, the majority of participants said that their time spent on recreation has been negatively impacted, so it has been reduced. This has been due to just a reduction in the amount of activities they've been able to engage in. And one reason for this, as identified earlier, is an attempt to cut back on costs to spend money towards things that are considered more essential. But another part of it is simply because some children don't have interest in participating in recreational activities, so some families opt to not do them at all. Regarding relationships, unfortunately, the majority of individuals indicated experiencing conflict with their partner or if they have other children with those other children. Caregivers have reported spending less time with their other loved ones since most of their time goes towards meeting their autistic children's needs. And oftentimes, there are some competing attentional demands between the autistic individual and other individuals, which kind of forces caregivers to divide their attention. And ultimately, if autistic individuals are prioritized, other family members sometimes feel unsupported or neglected. Of course, all of this would then have a strong impact on a caregiver's well-being, where almost everyone who completed our survey indicated experiencing moderate to severe stress overall as a parent. When looking at people's open-ended responses, a lot of the words that came up were exhausting and isolating to describe these types of experiences. However, these are only the negative experiences that were reported. There are also a number of positives associated with caring for autistic individuals that caregivers had described. First off, with recreation, of the small amount who have been positively impacted, as in having a greater amount of recreation time, a lot of people have seen this as a bonding opportunity because the activities that they are engaging in is matching what their child's interests are, and it kind of gives them something to engage in jointly. On the relationship side of things, some people indicated increased bonding with their partner and other children. And one of the reasons suggested for this is that people describe their communication becoming more intentional, and just being more in tune with other people's needs. Finally, on the note of well-being, a number of social and community supports were identified by caregivers as improving their well-being. Family and friends, of course, are a very consistent, great support on both the social side of things as well as the tangible material support side of things. Counseling and parent training are also described as being extremely beneficial for emotional as well as informational support. And finally, caregivers reported being members of a number of different autism-related organizations, such as the Children's Treatment Network, the YSSN, and Autism Ontario. And these organizations provide information on a variety of different services, as well as workshops that allow caregivers to speak with others going through shared experiences. So it's a form of social support in that regard as well. Now, that was a lot of information that we had just shared, so I'm going to send it back to Samuel to help me summarize everything that we've discussed, as well as what you can come away from this talk with.
Thank you, Gemma. So this slide specifically is summarizing the implications around the direct costs, takeaways, implications. So the first takeaway is that children with higher support needs and additional diagnosis require more paid services and therapies. The implication is that these funding formulas may need to account for this child level complexity rather than using one average estimate of cost impact. The second takeaway is that higher household income is linked to lower reported services and therapy costs. This doesn't necessarily mean that higher income families need fewer services. It may mean that they have private insurance, employer benefits, or other ways to cover services that reduce what appears as reported out-of-pocket cost. The third takeaway is that service and therapy costs and extra costs are driven by different factors. This means direct costs shouldn't be treated as one single category. Medical and service costs reflect one pressure, while non-medical extra costs are reflecting another. The last three rows are focusing on extra costs. Households with adult autistic children show much higher extra costs, which suggests families may continue paying for care-related needs after age 18, while having fewer child-focused supports. Higher need households also report higher extra costs, meaning families with greater care demands may be absorbing costs that formal supports do not fully cover. Finally, additional disabilities increase the extra cost impact. So supports should account for these layered needs rather than treating autism-related costs as uniform across families. The final implication slide focuses on indirect costs. The first takeaway is that subset of households are experiencing near full withdrawal from the labor market, mostly being women. This means policy responses cannot rely on average income lost or average hours lost because the impact is highly uneven, as we've seen. Some caregivers are facing very large employment impacts. The next implication is that autism-related care may reinforce existing gender gaps in labor force participation, earnings, and career advancement. If mothers are more likely to reduce hours or leave work, then the long-term effects can include lower earnings growth, weaker career progression, and reduced financial independence. The second main takeaway is that more intensive care needs pull caregivers away from paid work. Families face greater care demands while also having this lower earning capacity. And the final takeaway is focusing on only subsidizing medical or therapy expenses misses a large part of the economic impact. If the largest constraint is time, then families may need supports like income replacement, flexible work policies, respite, in-home support, or subsidized caregiving services. So the broader conclusion is that economic impact is both direct and indirect. Families are paying more, but many are also earning less.
And just to wrap it up with some other implications from what we found, one major takeaway is in regards to services, low supply of and high demand for specific types of services is oftentimes a major driver of unmet service needs. So what this implies is that policymakers and caregivers really should be maintaining an ongoing dialogue to discuss the accessibility and necessity of different types of services because service needs are continuously evolving over time as the availability of different services changes. Another major takeaway is that families with access to fewer public resources and those with higher support needs are oftentimes disproportionately affected. And what that means is due to these family-based differences, we should really be prioritizing delivering specialized family-level support based on demographic risk factors because resources are already somewhat scarce as it is. We really should be taking an equity-based approach to providing support. Another takeaway that Sam has already touched on to an extent is that workforce participation is often reduced to meet those caregiving demands. But another implication of this is that caregivers shouldn't have to be cutting back on their hours in order to address this takeaway, because as we've already established, maintaining a continuous source of income is very important to support all the costs that they face. Instead, there should be greater responsibility placed on employers to be able to have the flexibility to provide accommodations to caregivers. That way, they can maintain a better balance between employment and caregiving duties. One final takeaway we have is that challenges with information navigation often limit effective decision making regarding services. And like I said before, information navigation is a very complex process that's very multifaceted and inherently involves many different individuals. So while this might be difficult to address, one good way to start would be by improving accessibility of and awareness of service navigation supports that are available for families. Like I was saying before, typically after diagnoses, families are left out high and dry, so to speak, in terms of knowing where to go next. So by being aware of the different sources of navigation support they can turn to, it can relieve the burden a little bit and make the process a little bit easier to digest. Anyway, that is the end of this presentation. However, data collection for this project is still ongoing. We plan to continue to do more analyses and more results. If you're interested in learning more about this research, I've included the email of the primary investigator, Dr. Jingjing Zhu, on the slide. I've also included the publication based on the pilot study, which was published in Frontiers in Public Health. So a lot of things that we've spoken about today have also been described more in depth there. Otherwise, I believe we're taking questions now, and just thank you so much for listening to our talk.
Thank you, Emma and Sam. That was fantastic and a really nice sort of review of your work and very sobering in terms of what families have to face and puts it really highlights it. So we have lots of time for questions and comments. And let me start. There's a question in the question and answer from Fabian Gorodzinski, who's a pediatrician in London. And maybe difficult to answer, but as I said, ultimately it's around the Ontario Autism Program and concerns people have. So the question from Dr. Gorodzinski is there any way that OAP can decrease their waiting time for approval of funding from the present 2 to 3 years from the time of confirming diagnosis? And I think, Fabian, that when you say 2 or 3 years, that's probably very optimistic. Nowadays, I think lots of people are saying it's more like 4 or 5 now, unfortunately.
Yeah, dare I say it, we might be close to 5 or 6 because we've interviewed with families before and that's been the finding. I think the pandemic has really thrown a wrench in terms of the approval process, so it's really increased. Oh boy, if I had the answer for how OAP could decrease their wait time, I would tell them, but I have some ideas just from what parents and caregivers have spoken about before. It seems like at least not for the initial funding, but ongoing needs assessment has been something that people have had very mixed feelings on in terms of prolonging the wait times between receiving different bouts of funding. So, at least in terms of like a resource utilization standpoint, that seems like that might be an area that could warrant some attention. Similarly, some parents have indicated that they think it would be more efficient if they were able to begin the OAP waitlist process before they have received the autism diagnosis, but while they are going through the process. Just because assessments don't necessarily take as long to complete, but if there was some way to sort of tentatively state that they've received the diagnosis before being able to provide the formal identification to OAP, that maybe it would cut down on a bit. But again, considering the wait list is 5 years, 6 years, that might be kind of optimistic. But those were just some ideas.
So if I can, well, be devil's advocate somewhat. So the OAP was started in 2000 roughly, under different names, but they estimated at the time that the cost would be about $10 million annually to the province. And I think for 2025, the estimate was about $800 million. So staggering increase in cost. And it's gone up dramatically over the last 10 years or so. Despite that, the waiting list has actually gotten longer and longer. So it seemed that throwing money at it is actually probably not the solution to the problem, or it hasn't made a difference. In fact, I don't think more money has made as the cause for the waiting list getting longer, but it certainly hasn't changed it at all. I mean, do you have any thoughts about that?
I you say you're playing devil's advocate, but I think many people would agree with you in that regard, is that's this is like a broader systemic issue, the process of like the diagnostics to navigating OAP towards receiving ongoing funding, that I agree that you kind of have to address the whole system of how OAP operates itself as opposed to, like, as you say, throwing money at it.
Yeah, because it's a staggering cost and to the province, although I assume it's nothing for the provincial budget, I assume it's probably fairly small, but it still has increased dramatically. And despite that, waiting lists have got longer, which is a bit hard to make sense of in some ways, because you'd think if there was more money that they would be providing more services to more people, and that hasn't turned out that way. And I wonder if, well, I think that's pretty strong. I think by making more services available, that leads to the diagnosis being made more often, I think. In fact, I'm pretty confident about that, which creates problems also, unfortunately. Um, so the comment here in the chat from Bonnie Wooten, who, let me just see if I can find this here. Uh, where is that? Okay. So it says, as a shared decision-making decision coach, I'm wondering if you might think about educating families using this mode of care when making decisions on treatments and costs associated. So, uh, do Sam and Gemma, do you know very much about shared decision-making and decision coach?
Personally, I'm not too informed on it, no.
So, Bonnie, if you want to raise your hand, I can mute you or unmute you, I guess would be a better way to put it. And then we could and then if you want to sort of explain what you're talking about a bit, there you go. So you just have to unmute yourself and you should be good to go.
Okay, can you hear me?
Yep.
Okay, I am a decision coach at Children's Hospital. We've had a program here since 2018. I work with Dr. Campbell in Children's Hospital and working with all the teams. And it is, I listened to what you were talking about families struggling with decisions around treatments. And I think there are ways in which if the families were educated around what kinds of questions to ask the physicians when they're making recommendations, there are tools that they can say, what are the harms? What are the risks? do I need this medication? Is there something different I could use that would do the same thing? Is it needed right now? Checking in on costs and different things. It's just that these are strategies that we're trying to teach healthcare workers to also teach the families. But we do a lot of educating with families around shared decision making when they're struggling with decisional issues.
Okay, so I think the approach that you guys take to informing families is really good because it's not necessarily making decisions for families. It's almost more so like teaching the self-advocacy skills. That way families are informed about what to ask. I think one of the major reasons why we aren't quite at that point yet with a lot of families, and this relates back to being able to find information to help navigating services is especially like in today's day and age online, there is a lot of very conflicting information regarding what families should and shouldn't be doing and what resources are and aren't available. Not even getting into social media, different types of service providers have different knowledge bases for what decisions are better to make. So I think until that consistency established, while having these decision-making models are good, I think it might also, on the other hand, cause some more confusion for families about what is the correct course of action. But I think establishing almost a universal approach to like, here are some key questions that can help you with your navigation process to find out what's the right fit would be really good. That then you can take in combination with other people's service experiences.
You're correct. I think it's around the decision aids that are used, and that's what you're talking about. There are multiple decision aids for any issue or any healthcare issue, not just this one. So, trying to streamline that to get an appropriate decision aid that would give the families the information around the risks, benefits, the pros and cons of that, what they should choose, and leading them into making a final decision for themselves. As a coach, I don't make final decisions for the families. I just usually I just work with them to assist them in getting to a preferred decision. But we try to use decision aids that fit, that are tailored to their child, because one size doesn't fit all.
Yeah, I think that's a really good idea, especially for making the process a lot less overwhelming, where you're presented with all these different options and you don't necessarily know how to tackle them.
But I think Bonnie's point is good, and not just around treatment, but navigating the system, because the system as it's set up is not easy to navigate, that's for sure. And I often wonder, for people who are newcomers to Canada who may not speak English as a first language, I don't know how they are able to negotiate things sometimes because there's so many calls to make. And I think what would also help really a lot would be having a good case management system. So when somebody's diagnosed with autism, they're assigned or whatever we're talking about, a case manager who could sort of help them understand what their options are, who they need to talk to, and things like that. And it was supposed to exist, but really doesn't. I think that's a real loss, unfortunately. Thank you for that question, Bonnie. Ms. O'Flanagan, if you would like to go ahead and ask your question, just unmute yourself.
Yeah, hi, can you hear me?
Yep.
Okay, so hi, I'm Sarah. I work at the Institute for Neuroscience at Western. And I was just at an event yesterday specific to dementia, so not kind of in this wheelhouse, but it was making me think about kind of the other confounding factors that lots of parents of kids with autism are facing while they're also trying to navigate this system. So, assuming a lot of these parents are millennials, young Gen Xers, a lot of them also have aging parents and are likely to be involved in the caregiving for their parents as well. So I'm just thinking about different confounding factors that this specific generation of parents, when we're talking about the children having autism, are facing. So is there any uh, hopes or ideas to work with other disciplines and looking at kind of other confounding factors that are making it even more difficult economically for families? Because of course, people with developmental disabilities, you really have to look at the family unit when you're supporting. And unfortunately, often the child's needs are not the only thing the parents are thinking about, right?
So sorry, is the question about like further
Yeah, is there
collaboration in
any
this area?
hope to move the study in another direction or work with other disciplines? I'm just thinking that the data might be interesting for other disciplines to use as well.
So as of right now, mainly the collaboration, like I said, at the beginning has just been between like economics and psychology. But I know in terms of like dissemination efforts, we're trying to take a more participatory action research lens, which involves having a lot more of like self-advocates involved in
Right.
the research themselves. So I think through personal experience, we begin to kind of scratch the surface at some of those additional factors. But I
Yeah.
think
And
you
I
are
see,
right that further
yeah.
collaboration with other like models to factors
Yeah.
that might play a role would be
And
beneficial.
like what Dr. Nicholson was just saying, what Dr. Pabry just said, there's so many other confounding factors like language, like your status in Canada, how long you've lived in Canada, cultural norms, et cetera, right?
Yeah, I actually within our survey we did collect data on a lot of those variables. And Sam can correct me here if I'm wrong, but I think it was just a decision for these initial regression analyses not to include some of those in the model because they weren't very significant, or maybe just some of the data itself wasn't, it just didn't lend itself too well to the regression model specifically. But we
Yeah.
do have the data.
Yeah, at the moment we were actually looking into communication specifically. I personally have created a couple variables regarding each of these different levels, so it's a next step for sure. We played around with language communication, how well they're able to communicate, how well they're able to be social. So it's definitely a next step in the project. But when looking at communication specifically, that was the other one we were looking at. As opposed to support needs, it was not super significant in many of them, but we're early stages, we're playing around with them, and there were a couple where it came up, but just as of right now, it's not a super significant factor or variable within what we're looking at. But there's going to be more outcome variables we look at to see how they affect. So it's 100% a next step.
But Sam, I think that because you're talking right now about language and communication within the child, correct?
Yes.
And I think one of the points, my understanding was what Dr. Parry, who's in the had a question in the chat about language and social factors. I think she and Sarah were actually referring to language and the parents, so people who don't speak English as a first language, or people who aren't able to access services. So and I think especially when we look at single parent families, that becomes a huge issue with people, having funds for services but not being able to get there sometimes because if you have three kids and you're a single parent, it's not going to be easy to go certain places during the day or in the evening.
Yeah, we have a couple variables in the survey regarding immigrant status, including how long families have been within Canada, as well as if English is their native language and which languages are being spoken within the household. And while I don't think those have been looked into for the regression analysis yet, that's definitely something that can be thrown in as well, because I agree that is definitely such a huge factor in terms of the different types of financial decision-making processes that are made.
Yeah, I would agree. And that's actually a good point to bring up. I haven't thought about that, but it's definitely something we could add in and look at in the future. So I appreciate that.
Actually, Gemma, can you stop sharing for a second? 'Cause I want to show somebody a
Okay.
paper from the CC. And this leads to a question, but uh, where is, where is share? Oh, it's bottom here. Sorry. Where is it here? Okay, I will just do that and share. And then, can you see that paper there?
Yep.
Yeah.
So this is from the CDC, and looking at similar issues in the United States, and this is 20 some odd years old now, so the terminology is perhaps a bit outdated. But I think we can see though that what they talk about is indirect costs also. But I was wondering, Sam, and Gemma, so I mean the numbers that you talk about with families are really concerning, obviously. But have you had an opportunity to compare it to other conditions? Because I guess the question is not just how much does autism cost, but how is that in comparison with other things? Because there's a finite amount of money we have in the system. And so how do we decide where to spend it, I suppose?
As of right now, the focus mainly has been within autism, but I know Dr. Nicole Neal has been wanting to replicate much of our research for individuals with other intellectual and developmental disabilities. I think specifically like intellectual disability as well as ADHD, because yeah, autism, there's a lot more resources available for people with autism diagnoses that other diagnoses don't necessarily have.
But may have similar needs, particularly people with intellectual disabilities and more
Yeah.
severe.
If not more, if not different.
And in the comparison aspect of that, what the only real comparison, the additional disability factor
Yep.
that would be the only comparison we've looked at so far. But Again,
Was that like a linear thing? Like the more extra disabilities, was the cost higher? Like was it predictable or not necessarily?
oh yeah, yeah. So we could see that needs were definitely higher. When we have an additional disability layered on top of ASD, costs are much higher, especially in the extra cost category, I believe it was.
But I'm thinking more though, if people had two disabilities, so
Hmm.
let's say they had a hearing impairment and they were intellectually disabled as well as having autism or something like that. Does each additional disability or comorbidity, does it add incrementally to the cost?
Oh, that's also a good question. So our variable wasn't set up like
Okay.
that. It was more set up as if you have an additional disability, so it didn't go into specifics like that. I think that was more so due to the sample size we currently have,
Yep.
because initially it was set up to look at each of these disabilities on top, and it didn't work out with the sample size. So I think as that grows, we can look more into several disabilities, one, two, or more on top.
Yeah, because I think sometimes people, some studies have found sort of linear increases with more disabilities. So I just want to ask you about the indirect cost, because that's the one I assume requires the most assumptions statistically. So how did you actually, like, what questions were parents asked about this? How was that assessed?
So for income loss specifically, this was something I derived my own methodology for it to create the variable. So we had stuff like annual income, hours worked, stuff around that sort. So I was able to conduct a variable to get their hourly wage and then take how many hours they're working per week. And the assumption there was, of course, they're working a linear amount of hours each week, continuous. And then we can kind of see, we also had weekly hours lost. So it would be an hourly wage multiplied by an weekly hours lost to find how much annual hours they're losing. It was all converted annually to find out how much annual hours they were losing there. For the indirect cost of just how many hours they're losing, that is something we collected within the data already. So there wasn't really an assumption there. This was something they gave us, other than the fact, well, when they say they're working or they're losing, say, 10 hours weekly, we assume that's every single week for a whole year.
Yeah, because that study from the CDC I just showed you, I think what they did in terms of additionally, and they had, the entire United States, right? So it was a massive sample size, but they actually looked at lost wages on the part of the child, sort of future lost wages compared to what would have thought they would make in the future, and included that in their indirect cost to families. And eventually they concluded that, the lifetime cost of people born in 2000, I think, with developmental disabilities, the cost of the United States over the course of all those people's lifetimes was about $50 billion. And that was in $2,000, right? Because you're talking about a huge population. But they, as I say, they included people's lost future earnings for the child with a disability. And so that, I assume, again, that's going to be all kinds of assumptions that are made or something
Yeah.
like that.
So that was actually something I was looking into initially before I devised the methodology to make our income loss variable would be the counterfactual income I wanted to look at initially, which would be what would they have made as opposed if they didn't lose these hours. But I remember when I was looking into it, it was just way more assumptions than what I had to do
Yeah.
so income loss was just a better thing to look at, especially regarding with our sample size.
But I think it's great that you look at indirect costs because that again is going to be the kind of thing, we can look at direct care costs and things, but it's often, as you said, the indirect costs are going to be huge.
Mhm.
For families. And I think the CDC also did something similar, looking at lost wages on the part of parents, and found again that people with disabilities, their parents tend to make much less than you'd predict based upon their education and things like that
Mhm.
as well. Diane Rogers from CPR has a comment or a question. Was the ASD level collected as a part of the data? So in terms of severity, right, the DSM breaks it down into level one, two, three. So were you able to look at that at all?
Yeah, so based on severity, this is actually another variable created. So we have questions in there. I'll give an example. So for support needs, you'd have five different options there. It would be no extra support needs, mild, medium, high, all aspects of life. So the variables created off that, I looked into about some other literature and kind of used a very common way as the lowest was zero, and then one, two, three, four. And then 0 and 1 were actually combined for the regression sample size issue again, so it was sort of collected within the survey, but the variable itself was made in that way.
But
Yeah, I
and
can.
so with higher needs, predicted higher costs, as you
Yes.
said.
Yeah.
Yeah, I can elaborate on that a little more. We didn't take a level one, two, three diagnostic approach to assessing autism severity, mostly because we wanted to include some older autistic children that might not necessarily have been diagnosed using that approach. So the support questions that Sam is talking about are actually based on the Go for Kids brief adaptive scale, which includes questions for each of the core autism criteria, as well as some maladaptive behavior, which is often used as a screener to kind of assess general autism severity. So no necessarily level 1, 2, 3 diagnostic, but we did take a validated approach to assessing autism severity.
So is that Go for Kids model? Is that from Adrian Perry at York?
Yes, it is.
Oh wow, okay, I remember that study. But I think and I wonder too, based on what you just said, I'm not sure, Diane, about the reliability, like the inter-rater reliability of these severity levels, like the level 1, 2, 3 in the DSM, because I've never seen a study that actually looked at the validity or the reliability of that particular approach. So I think it was put in DSM-5 as a way to try and quantify it, but it's not clear how meaningful it is. Um, and it's a question about your paper that you published. If you want to put that up again, Gemma, just if you want to get that reference.
Yeah, sure thing. Give me a moment here.
While you're doing that, Sam, I had one question. So I think in the research you quoted on lost work hours, I think that the number of lost work hours that a direct parent had was less than their partners had, because one was 15 and one was 17.
Yes, that is true. That was something I was thinking about as well, but we also find that partners altogether work a large majority more, some even 20 plus hours more. So I think in that sense, it's partners are working so much higher hours that potentially that their loss is more prevalent than a caregiver's loss. But yes, that was a finding we had.
Oh, but so partner in this case then means the parent who didn't respond to the questionnaire.
Yes.
And it said it was mostly females responding to it, so presumably mostly males then. Who
Exactly.
historically, yeah, spend more work hours and less time with their kids. So, okay, that makes complete sense. So I was thinking when I said partner, I thought it was like parents who were not together and the partner that a parent, like if they'd remarried, that their partner was losing more hours. And I was trying to figure out how that actually would work. But now what you've said makes complete sense.
Sorry, I should have clarified that earlier. Yes, all respondents are considered the caregivers, and then partners are the
Okay.
respondents.
And for anybody who wants it in the chat now, is the link for the paper that Gemma had talked about that was published last year or this year?
Published last year in the fall.
Are there other comments or questions people have? Just a really, I think, important topic, and we see it all the time. And I think the other thing that you talked about was the stress on families. And I just, before I joined, I was with a family, and and their son is older. He has a lot of behavior problems and been in trouble with the law. But both of the parents, their mothers, so the grandmothers on both sides of the family are in a sort of early to mid-stage Alzheimer's disease at this point. And so they're having to look at placing them in alternative residential placements and things. And so it just does compound things. Life, it's never just one thing, I think, unfortunately. All right. Well, thank you both, Gemma and Sam. This was great and really very thought-provoking and important for us to think about. I guess that's why it's thought-provoking. But about what other burdens our families have to face, what other difficulties they have to face, and that it's not just about helping to treat the child. It's also around what we can do to help the whole family, I think. So I appreciate it. Thank you very much. That was fantastic. So just for our next rounds, the last ones of this calendar year, this academic year, are on June the 10th. And Dr. George Ibrahim, who is a neurosurgeon at the University of Toronto and at St. Kitts in Toronto, he recently has done some research using deep brain stimulation for people with severe self-injurious behavior, and has published an open-label trial of that and is looking at a randomized double-blind trial. But anyway, so Dr. Ibrahim is going to talk about the use of deep brain stimulation for neurological and neurodevelopmental disorders in children, and that will be on June the 10th at 4 o'clock. So we hope to see everybody there. And again, Sam and Gemma, thank you. This was really excellent.
Yeah, it's a pleasure to talk about these years of work that we've been putting into this project.
Well, I'm glad to hear that. All right. Take care, everybody.